One of the patient attender has given papaya leaf extract to our ICU patient, which has caused severe irritation and emetemesis. Then later we came to know that without the knowledge of sister and the resident doctor, they have given, and patient had emetemesis. So as you know, these can be watched carefully. Not only these, but other Ayurvedic or other parallel medicines can be used during this condition. So examination, as you know, pulse, respiration, pulse tachycardia, relative bradycardia. Relative bradycardia is seen in enteric fever. Sinus bradycardia is commonly seen in dengue fever. Tachypnea is very important because it indicates there is ARDS, especially when patient is afebrile. Hypoxia should be seen, again respiratory involvement. Hypotension indicates shock. So it's important red flag sign where patient has to be monitored carefully. Sclera and conjunctiva. Jaundice is very important, especially in hepatitis. Very easily you can make, especially viral hepatitis, where fever disappears after onset of jaundice. Candidal infection are very common, especially in immunocompromised conditions. Throat and mouth examination is very important. Most of time we neglect, where you can pick up tonsillitis or pharyngitis, diphtheриal rash, or dental abscess, where if you find these signs, you can avoid a lot of investigations. Lymph nodes, as you know, whether it is matted, generalized, localized, the Skelny group of lymph nodes are enlarged, that help you to make a diagnosis. Sometimes if you don't examine the axillary lymph node, you may miss the diagnosis of lymphoma or malignancy. Skin rashes, ulcer, abscess, nodules. We have made many diagnoses of atypical Mycobacterium tuberculosis, Kikuchi's disease, just picking up the abscess. Axilla and groin, again, as I told, lymph node and abscess has to be examined. As you know, systemic examination can do respiratory system, look for bronchial breathing, pleural effusion, signs, parabdomen, hepatosplenomegaly, and rigidity guarding has to be examined. Cardiovascular system, pericardial rub or change in murmur indicates pericarditis or infective endocarditis. Another important sign is necrosity and Kernig sign. So any fever patient comes to us, you should not miss meningeal signs along with the lymphadenopathy. These are the two things many times we miss, that is lymph nodes and necrosity. In bones and joints, spine abnormality, tenderness and joint inflammation has to be seen. So in generalized lymphadenopathy, infection, viral, EBV virus, HIV, cytomegalovirus, dengue, rubella, measles can cause lymphadenopathy. In bacterial, common is tuberculosis, syphilis, leptospira, brucellosis, fungal histoplasmosis and cryptococcal meningitis. Recently we have treated one cryptococcal meningitis in immunocompetent young fellow from Mandya, but we have given almost treatment for 1 month, but patient succumbed to the disease because of the uncontrolled diabetes. The protozoal infection like toxoplasmosis, leishmaniasis also should be considered. Malignancy is one of the important differential diagnoses most of the times we miss. We have seen renal cell carcinoma presenting as fever, or a CA pancreas presenting as a low-grade fever. Paraneoplastic syndromes also should be kept in malignancy. So malignancy should be kept in mind. Connective tissue disorder is one of the important differential diagnosis for acute febrile illness, but here one of the important thing is low-grade fever with joint involvement, multi-organ involvement can be seen. Recently we had one case with a patient presented with only fasciitis, palmar fasciitis, rheumatoid arthritis. Patient didn't have any other symptoms. Sarcoidosis is one of the challenging disease for a physician, where many times it causes multi-organ involvement with subtle signs and symptoms. So it has to be picked up early. So drug reaction and amyloidosis or HLH are the other conditions which cause generalized lymphadenopathy. So coming to differential diagnosis of physical findings, as you know, hepatomegaly can be seen in amoebic or liver abscess, hepatitis, leptospirosis, malaria, the splenomegaly, enteric fever, brucellosis, dengue fever, tuberculosis, toxoplasmosis. So jaundice, one of the important signs, hepatitis, malaria, leptospirosis and relapsing fever. So some of the surgical conditions like cholelithiasis and pancreatitis should not be missed whenever there is a icteris there. So wheezing indicates there is a respiratory involvement. You have to ask history of previous history of bronchial asthma or allergic airway disease. Commonly what we have seen is COVID-19 and H1N1 or other viral infection which commonly affects wheezing and respiratory infection. Localized wheezing with hemoptysis is one of the important signs in endobronchial tuberculosis. So maculopapular rashes are seen in arbovirus, rickettsial fever, typhus, typhoid, disseminated gonococcal and meningococcal infection. Very important because if you pick up these rashes early, so you can minimize the investigations. So petechiae and ecchymosis again, if it is there again, you have to suspect rickettsiosis, meningococcal infection, viral hemorrhagic fever, dengue, leptospirosis, sepsis also can present, can have these signs, and one more is DIC. So if you pick up these signs, it is minimized the investigation. SR is another important sign where you can diagnose tick bite fever, scrub typhus and anthrax. So distributional pattern of rashes is centripetal and centrifugal rash. Centripetal rash you can occur in rubella, roseola, scarlet fever, parvovirus, varicella and measles. So you can mnemonics for PGs you can remember: red rashes scare parents very much. That is RRSPVAM. So that can be remembered. The centripetal rash usually occurs in the face and the chest and the upper limb proximal part, whereas centrifugal rash is distributed distally, occurs in Coxsackie A virus, Rocky Mountain spotted fever, smallpox and secondary syphilis. Mnemonics again you can remember is CARS. So recently we had one patient with a lawyer from Mandya. He had a parvovirus infection leading to pancytopenia. Now patient has completely had a bone marrow failure. Now he is on bone marrow transplantation. So these viruses are very difficult to diagnose unless you suspect. Nowadays in our hospital we got a lot of advanced investigations are available. I thank to our management. So we were able to make a diagnosis of these type of rare diseases also. So other photographs, you can see the first slide, there is a dengue hemorrhagic fever. Second one is meningococcal infections, again HR. Then this is rashes can occur in the maculopapular rashes in brucellosis. So these will give you the hint of diagnosis where you can pick up these signs and make a diagnosis. That's why I tell my PG students, if you miss a sign, you'll miss the diagnosis. So that's why clinical examination is very important, even though you have any number of advanced investigations. Vesicular rashes can be seen in herpes simplex and varicella. So how to attack fever? So one is, you know whether it is less than 14 days, sorry there is a 21 days is there, less than 14 days or more than 21 days, you can diagnose either AFI or PUO. So initial assessment you have to examine for altered sensorium, hypotension, tachypnea. Then later whether there is a localizing symptoms are there. If there are localizing symptoms are there, you have to treat the respective system. One of the commonest infection you see in diabetics is urinary tract infection. Many of the cases are coming with UTI, pyelonephritis. So if like that, patient, you have to localize the infection and treat the patient. Exanthematous fever has to be evaluated, and hepatitis and jaundice should be evaluated. So what are the investigation you do? In the first 2 to 5 days, NS1 antigen, or first week, blood culture for salmonella. So IgM investigation should be done at the end of the second week, or early second week you can do dengue, leptospira, typhi, DART. If you do early, it is a waste of money. Then rapid diagnostics are malaria, rapid diagnostics test, it is a negative predictive value, whereas NS1 antigen has got a high predictive value. Fever with hepatorenal involvement, leptospira, scrub typhus and enteric fever. Jaundice after fever is hepatitis A to E you can suspect. Fever with pulmonary involvement is scrub typhus, complicated malaria, hantavirus, legionella pneumonia and leptospira. Nowadays we are rarely seeing malaria. I don't know whether the COVID has the effect on this parasitic infection or is there any effect of Swachh Bharat on the malaria. Fever with rash, again rickettsial infections, dengue, leptospira, meningococcal meningitis. You can suspect fever with ARDS, we have to do blood gas analysis, X-ray, where it is caused by scrub typhus and leptospira and influenza. Fever with encephalopathy, where you do MRI brain, CSF examination and EEG. The commonest is simplex encephalitis or Japanese encephalitis, scrub typhus and cerebral malaria. Fever with multi-organ system involvement, where you can see malaria again, leptospira, scrub typhus, hepatitis A to E and hantavirus. So if you see all these pictures, the most commonest infections are seen are leptospirosis and scrub typhus and rickettsial fevers next to followed by enteric fever. So one of the study done in CMC Vellore has shown around 1,258 patients, 35% of scrub typhus, 30% of dengue, malaria and 10% enteric fever and 3% leptospira and 8%. Undiagnosed cases were 17.5%, mortality was seen in 2.7%. These are the studies done in Thailand, USA, in the Anugrah study et al. Done in South India, and one of the study done in our college has shown leptospirosis and scrub typhus are common infections. Next was dengue infection. So dengue usually now it is high because of this, because of the June to September because of the rainy season. So unknown cases, as you see in the last row, it is not seen, are more, especially it is around 20 to 50%. So other studies done across the world has shown between 30 to 80% of cases were unknown. That is because of lack of advanced investigation is one of the cause, and the cost of investigations are also high. So can biomarkers guide on treatment of febrile illness? One of the study done by Varadaraj and Govindaraj in a tertiary care armed forces hospital in New Delhi has concluded that rapid diagnostic tests are widely used for the detection of common etiologies of fever are unreliable. The rise of various inflammatory markers may help to identify the probable etiology. So this is one of the author comments, but according to me, this is not only the markers, it is also the examination and the initial investigations are also important. And also one of the important thing is you have to demonstrate the rise in titers, not only just initial rise in titers may not be helpful for the diagnosis, so you have to show the rise in titers. So these are the another study has shown CRP is highly elevated in enteric fever, in dengue and COVID-19 D-dimer is highly elevated. In scrub typhus, CRP and ferritin is highly elevated. This is another biomarker testing. It has shown if you see the right upper quadrant, the specificity and sensitivity are high, but there are advanced investigations like RNA markers or protein markers. They are costly, but if you see CRP and PCT in the purple and blue, they are in the less sensitivity specificity, but however, this is the common investigation we use and they are also helpful. So future diagnostic approach like metagenomics, where genetic material from the environment is collected from the clinical samples, which doesn't require knowledge of the pathogen or no need to grow in culture. So these can detect previously unrecognized pathogens, and also it increases the knowledge regards the microbial diversity. For example, if there's a Nipah virus is found, so you have to collect a lot of samples surrounding the area, then you have to analyze the genetic material so that you can detect new virus or other organisms, and you have to analyze. So alternate methods are proteomics, multiplex, PCR and microarray hybridization. So if somebody says that if they need antibiotics, most of the times it is virus. So management strategy will not go into detail. Fever, thrombocytopenia, supportive treatment, fever with jaundice, You give ceftriaxone, doxycycline.
I think we are running short of time, sir.
2 minutes, madam, 2 minutes. Fever with renal failure, ceftriaxone can give. So fever with encephalopathy, you can close your eyes and start ceftriaxone and acyclovir before getting CSF analysis. Fever with respiratory distress, ceftriaxone, azithromycin and oseltamivir can be used. This is one of the interesting cases I will tell you. These are the last 2 slides. So this patient came with 3 days of fever. We did lot of investigations. All investigations are negative. Next we did a patient presented with fever with lymphadenopathy. We did a FNHC of lymph node, bone marrow biopsy, CKNAC, all markers of malignancy, CT thorax, MRI spine. Then we kept a diagnosis of leukemia, lymphoma, IG4 related disease, vasculitis. The FNHC of parotid gland and biopsy of the cervical lymph node we sent for immunohistochemistry. Initially it was shown non-Hodgkin's lymphoma in Jesus Hospital. They also told it is query, but when it was sent to Bombay, they diagnosed as a immunohistochemistry showing no evidence of NHL, but EBV RNA was detected by in situ hybridization. So this is the role of present advanced investigation, and the final diagnosis we concluded was ABV induced leukocytoclastic vasculitis with GB syndrome with a multi-organ involvement. Patient has to stay for 2 months in our hospital for this diagnosis. This is okay. So clinicians should be aware of classical clinical pattern described in the books, may be masked, and absence of classical pattern of illness should not be considered to rule out any tropical infection. And history is important, and clinical examination is equally important to elicit signs and symptoms. Thank you. Thank you, madam.
Thank you for a very lucid and succinct presentation, sir. Sir, if there are any questions, please.
Thank you, sir, for taking the time to speak with us. It was a privilege to hear your thoughts and ideas. With great pleasure, I invite our chairpersons to present a memento to Dr. Shashidhar Kesi as a token of our appreciation.
Because the sessions are being and the next set of chairpersons don't be just be at the point. Day one,
Navigating the complexities of autoimmune disorders require both advanced treatment options and compassionate support.
Our next presenter, Dr. Satish Chandra, will be speaking about the approach to the problem of multiple sclerosis.
We, the chairpersons of first session of KAPICON, all three of us are students of Satish Chandra sir, and we are really humbled and honored to chair this session. Over to you, sir. Thank you, sir.
Yeah. Slide. Connecting.
Sir, first one.
Pointers here.
So this one, sir.
Okay.
Okay, sir.
Yeah. Good morning, chairpersons and friends. At the outset, I thank the organizers of KAPICON